so first of all, quick review. GTO, Golgi tendon organ. It's the receptor, of course, it's found within the tendon itself. It's squeezed. The dendrites are squeezed by the collagen fibers when the muscle generates any force, and therefore this receptor is responsible for signaling force to the brain. Subconsciously, it signals force to the cerebellum, and it's also responsible for this inverse myostatic reflex. Okay, so as well as just telling the body, the conscious brain, in other words, the cerebral cortex, about how much force is going through the tendon, it tells the cerebellum how much force is going through the tendon. But at the reflex level, at segmental level, there's an inhibitory interneuron that tends to turn off the muscle that comes from autogenic inhibition. Okay, so it's a muscle receptor, it's a force receptor, and high forces it can turn the muscle off. Autogenic inhibition. This is the basis of some of our treatment approaches in stretching, etc. Okay, so 1B afferent comes out of the GTO. This has got nothing to do with the stretch reflex. This has got nothing to do with the patella tendon tap ligament reflex, whatever it's called. Okay, and that was just a review of that. The muscle spindle is much more complicated. It has a motor component and a sensory component. The intrafusal fibers within the muscle itself. Okay, there are different types of sensory fiber that are emanating from the muscle spindle. That's probably one of those two diagrams basically encapsulate everything you need to know about it. The 1A afferent coming off all those bag and chain fibers. That's the dynamic afferent. The type 2 afferent, the static afferent comes off those apart from the dynamic nuclear bag fiber. The 1A fiber, remember, is going to monitor the rate of stretch, how fast the muscle is being stretched, the velocity of stretch, the velocity of change in length. The type 2 gives us the amount of stretch, okay, static stretch, the length of the muscle. These are, in fact, thought to be the primary receptors in actually determining muscle joint angle. They used to think we have joint receptors around the joints, which tell us, they think, is my elbow at 90 degrees, 50 degrees, 20 degrees, whatever. But they're not as accurate, or not as important as these muscle receptors, these muscle spindles. You know how far your elbow is bent by how much the muscles around that joint are being stretched. So they give you, as well as this length of muscle, they're also thought to give you angle of joints. Okay, so they're very important in telling us, giving us proprioception about our body, what's going on in our body. What is alpha-gamma coactivation? Why do we need it? Okay, remember there's various ways you can stretch it. The non-equatorial center of the muscle spindle is where we house our receptor sites. We can stretch that equatorial region various ways. One of them is by just passive stretch, okay? Like the knee-jerk reflex. You could all draw the neural circuitry of a knee-jerk reflex, couldn't you? Okay? The other way is relaxation of extrafusal fibers. So if the muscle that this muscle spindles lie within relaxes and stretches, you will stretch the muscle spindle. The other way, of course, is by contracting the intrafusal fibers. Okay, you contract the intrafusal fibers, you can't help but stretch the inside of the muscle spindle, which will cause them to fire. This was the basis of Merton's follow-up servo mechanism. This is the way they used to think you controlled your muscles. It's not the way you think we do it now, but there's some important points within that mechanism that I think we'll just go over, because we do control our muscles sometimes. We set our muscles, should I say, using gamma gain. Okay, let's look at that Merton's follow-up servo mechanism. So what he proposed was, let's pretend here's my biceps, okay, and lying within that are the muscle spindles. And the muscle spindles have there's my muscle fiber, the intrafusal fibers, and there's the, okay, makes sense? The non-equatorial region, muscle fibers at the ends. Alright? So there's the receptors on there, and here's the gamma motor neurons. Here is the alpha motor neuron. Remember, alpha motor neurons go to extrafusal fibers. Gamma motor neurons go to the intrafusal fibers. Okay. What Merton proposed was, because when you record from alpha and gamma motor neurons, when you artificially electrically stimulate the brain, you'll find gamma neurons fire first. So what he proposes, the way we control the length of our muscles is by first setting our spindles. So in other words, you would send a signal down the gammas, you would then make sense? So you first send a signal down the gamma motor neurons, and you cause the end of the muscle spindle to contract. You contract the ends, what happens to the middle bit? It gets stretched. From that diagram to this diagram, you can see the middle has been stretched apart. If you stretch the middle, what happens? The 1A and type 2 will fire. Okay? They will then feed back into the spinal cord, where they synapse with alpha motor neurons going to this biceps muscle. Okay? So then what you do is you follow up the muscle spindle, you copy the muscle spindle with the biceps. So the biceps now contracts, and you take off the slack in the muscle spindle. Does that make sense? So I stretch the muscle spindle out first. The muscle spindle does not like to be stretched. So what does it do? It tells the biceps that it lies within to contract, to shorten. You shorten the biceps, you then take off the stretch in the muscle spindle, and we're all happy. Does that make sense? So it's a follow-up servo mechanism. The biceps follows up the length of the muscle spindle. A servo mechanism. You control a little bit of force here with the gamma motor neurons, and you make a lot of force for the biceps. If you contract all your muscle spindles at the same time, you will not move the muscle. There's no force generating capability in terms of doing bicep curls with your muscle spindles. They're so small. So this is what's known as Merton's follow-up servo mechanism. It's not the way we typically control muscles now, though. Okay? Because the delay in the system. We don't want this delay. So what we send a signal down the alpha and gamma at the same time. But it's important to notice this mechanism is the same. It's the mechanism you control and then the muscles. So if I want to bend my elbow to 90 degrees, I want to hold it at 90 degrees. I have now set my muscle and my intrafusal muscle at a certain length, gamma gain. I've set the gain of my gammas at a certain angle. If my biceps get stretched from then on, I will detect it. But you've got to shrink your muscle spindle at the same rate and the same length as the biceps, or else it's worthless. Okay? You've got to shrink your biceps down. I mean, your muscle spindle down. You don't want a muscle spindle that's floppy because it's no good. So the gamma system is designed to keep contracting the intrafusal fibers to allow the muscle spindle to be continually sensitive to stretch at any part in its range of motion. Okay? And this is a myotatic reflex, of course, where a muscle spindle's job is to turn the muscle on that it comes out of. That's how you get your knee-jerk reflex. Your change in length causes contraction of the muscle it comes out of. So your muscle spindle, your knee-jerk reflex has got nothing to do with the Golgi tendon organ, even though you're hitting the tendon or the ligament. It's actually the muscle spindle that's causing that, the inverse myostatic reflex. You could all draw that, couldn't you? I'll make it a little more complicated. This is what it really looks like. Okay, let's put quadriceps, hamstrings, in terms of antagonistic muscle. Okay, so muscle spindle. I'll draw it and you tell me what's going on. One A, whatever, 1A and 2, whatever. Here's my cord. Okay? All we've done so far is this. Right? We've seen this. Okay, you all understand that? Can you all see that? So I tap the person's patellar tendon. It causes stretch of the muscle spindle. The muscle spindle, that 1A, those afferents go into the cord where they synapse with alpha motor neurons going to the quads and cause the quads to contract. You cannot contract the quads unless you turn off the hamstrings. So there's an inhibitory interneuron going to the alpha motor neurons going to the hamstrings. You never ever see this, which people will do in an exam. I'll show you what they'll do. Here's the cord. Quads, hamstrings. What is wrong with that diagram? Do it again? Alpha motor neurons cannot be inhibitory. So they'll say, oh, I want to turn off the hamstrings, right? So let's put an inhibitory alpha motor neuron to do that. That does not exist. There are no inhibitory alpha motor neurons. There's no such thing as this. Okay, so people do that, so don't ever do that. But this is what also happens, which we haven't looked at before. What the heck is that? What is happening there? Exactly. This little fella here is called a Renshaw cell. After Bertie Renshaw, who discovered these. That Renshaw cells are inhibitory interneurons within the segmental level. Its job is to turn off the muscle it came from. Sorry, turn off the alpha motor neuron it came from. Okay? This is known as recurrent inhibition. Recurrent inhibition. So, if we follow the signal coming down this afferent 1A alpha motor, 1A neuron, afferent neuron, comes down here, goes along and turns on the quads. But a short delay after, as it goes down here, a collateral peels off and activates this Renshaw cell. That Renshaw cell then feeds back to the cell body, the dendrites, of the alpha motor neuron that turned it on. So it turns off the alpha motor neuron. Okay? So it limits the activity.
What did you say? They turn off the muscle it came from?
Not the muscle. I said it turns off the alpha motor neuron they come from. So the alpha motor neuron, as it fires down to the muscle, on the way towards the muscle, it sends a little collateral off to this Renshaw cell. That Renshaw cell is an inhibitory interneuron that turns off their alpha motor neuron it came from, signaled it. Okay? And also, it inhibits the inhibitory interneuron to the antagonist. So this limits the amount of activity or the amount of knee extension you get. So your knee doesn't extend forever. It has a short burst and then stops. The current inhibition, it turns the quads off basically after a burst goes through. There's a lot of debate exactly what these Renshaw cells do. There's a lot of research on these and these arguments about these, because what it also does, get into this, it also does this. It basically turns off this alpha motor neuron's friends or mates next to it. Other alpha motor neurons lying next to this one will be turned off. So it's thought, it's getting complicated now, but it's thought to focus activity down certain pathways. It basically turns off the noise within a segmental level. All these alpha motor neurons have got a background firing. This one, the Renshaw cell, turns off the alpha motor neuron pool, tries to damp it down, but allows, if this 1A is highly activated, it's going to blast through that inhibition and keep going. But this Renshaw cell is going to turn off the alpha motor neurons' competitors, sort of, not competitors, but it's the other alpha motor neurons that sit next to it. So it's thought to focus the signal down highly facilitated pathways. Does that make any sense? No. Take-home message about a board's question on Renshaw cell. Remember, they are going to be inhibitory interneurons within a segmental level. Inhibitory interneurons. Renshaw cells. Link those two sort of thoughts together, and they'll be responsible for recurrent inhibition, which is turning off the alpha motor neuron that initially turned the Renshaw cell on. That last bit about focusing, blah blah blah, if you don't get that, you probably will get a board's question on it. There's a lot of debate in the literature about what these things do. But it's clear that they are inhibitory interneurons, and they will turn off, they will limit the activity going to the agonist and excite the antagonist. That much we're clear about. That's the Renshaw cell. Okay? Let's move on a little bit, hopefully. We talked about the stress reflex. Spasticity, remember, the traditional interpretation how the spastic response occurs after a stroke, after a spinal cord injury, after a TBI, is loss of inhibition from a supraspinal level. It is the reflex, the stretch reflex, that is hyperfacilitated. So remember, the definition of spasticity is a nonlinear increase in resistance to motion based on the velocity at which you get stretched. So if you stretch a person slowly, you don't get a lot of resistance. You stretch a person quickly, you get a massive amount of resistance. In other words, the faster you stretch somebody, a spastic muscle, the more it resists you. That's the definition of spasticity. That is not hypertonicity. It's a type of hypertonicity. You can get rigid muscles for many, many reasons. But spasticity, that term, is reserved for that resistance that is caused by the stretch reflex. Okay? And there's a debate why that occurs. Well, they clearly will say that the loss of descending control from the brain, because of the brain lesion, the cord lesion, at the segmental level, allows the stretch reflex to go crazy. It's hyperfacilitated. Some people will argue it's the muscle spindle itself that gets hyperfacilitated. Those equatorial regions, for some reason, are hyper. And so a small stretch will cause the fire. Some people will say these alpha motor neuron pools within a segmental level are hyperfacilitated. They're on a threshold of firing. So a slight stretch causes a lot of contraction, inappropriately. Okay? Some people will think it's the gamma motor neurons that are hyper. So some argument will argue that if your gamma motor neurons are hyperfacilitated, they sit in the ventral grey horn too. If they are close to the threshold, a slight stretch will cause them to fire to the intrafusal fibers. They in turn, of course, feed back and turn on the extrafusal fibers. Other people will argue spasticity is a result of the antagonistic activity. Too much. If I'm stretching my antagonist, you're going to sort of maybe cause the agonist to fire. You know, because you're stretching. You contract my triceps. I'm going to stretch my biceps, aren't I? And that causes the biceps to fire, and therefore I get spasticity. So there's many places within this reflex arc that can cause the spastic response. But this is the traditional notion of why we get spasticity. And it's not the same as normal, just general hypertonicity. So there's various things, treatment for this, you can stretch, you can drug the person with Botox, right? You can kill a neuromuscular end plate, reduce the muscle firing. You can give him baclofen. Has anyone seen a kid on baclofen? You've heard of baclofen? Yes? You basically, if you give them too much, they're very, very floppy and worthless. If you don't give them enough, they've got, still got spasticity. Usually you'll see, but you often have an intrathecal pump embedded in the stomach, and it'll drip into subarachnoid space. They'll just drip baclofen into the subarachnoid space all day long to reduce this muscle tone. You can take it orally, but you have to put it on such high doses to cross the blood-brain barrier. It's not you get a very, very drowsy, floppy kid if you take it orally. So usually they try and drip it into the spine if they're going to use this, an infusion pump. The other thing you can try in a spastic diaplegia kid, of course, will cut the dorsal roots. Remember, if this spasticity is a result of hyperactivity of the muscle spindle, the 1A and type 2 fibers coming in, causing too much contraction, what we'll do is go in there and do a dorsal rhizotomy. I've mentioned that before, yeah? They'll cut some of these rootlets to try to reduce the drive to the alpha motor neurons. And kids with spastic diaplegia often will have a dorsal rhizotomy. Not often, but depends where in the country you are. Some doctors do that all the time, so they won't do it. The complete contrast to that is that maybe spasticity is not a direct result of the lesion, it's a deliberate adaptation by the patient, which is very controversial, very new, and blasphemous for many therapists to say that spasticity is a deliberate attempt by the patient to get some tone in the muscle. So the spastic diaplegic kids who bounce on their tiptoes, talk about remote control, this is a deliberate attempt. They've self-organized, they've given themselves 2 pogo sticks because they were born with inadequate control of the gastrocs. So if you've got very floppy gastrocs and you can't control them, you can't walk. So what these spastic diaplegic children do is self-organize and make 2 pogo sticks in their gastrocs, and they bounce around on tiptoes all day long. Some of you have seen a spastic diplegic child walk. They're using this potential and kinetic energy in the gastroc, storing it and bouncing around onto these two springs. Okay, so in that case, some would argue that spasticity is kind of good, and they've deliberately adapted, found that solution. But that's not traditional. A traditional approach is spasticity is bad, all spasticity is bad, we need to cut it out, stop it. Okay? Okay, let's move on. We're going to go look at some more other cord-mediated reflexes. So the type of stimulation signal will determine the response of the muscles. Here is what's known as the flexor withdrawal reflex. Okay? The flexor withdrawal reflex. You can follow that through, but basically a flexor withdrawal reflex is when you put your limb on a painful stimulus. In this case, somebody pricks the hand, or you put your hand on a hot plate, or you stand on a thumbtack. Okay, that pain signal, those pain fibers, we can talk about pathways in a minute, go into the spinal cord and synapse with the alpha motor neurons for the flexor muscles, which will withdraw the limb from the painful stimuli. This is a segmental reflex. This is not the brain telling you to do this. So if you put your hand on a hot plate, on a burn on a stove, you pull the hand away almost instantly. Like it feels like a second later you feel the pain. That's when it gets up to the brain and it says, oh yes, that's hot. But before you actually know it's hot, your hand is coming away from that hot plate. Or you put your foot on a pin. You instantly pick your foot up. You don't think, ow, that hurts, I better bend my leg. Your hamstrings are automatically activated if you put your foot on a sharp, painful object. And that's known as the flexor withdrawal reflex. It's a segmental level, does not require a brain to do this. This is usually coupled with the crossed extensor reflex. The crossed extensor reflex, and these are detailed or gone over in one of those PDF files I put in your first class folder. I know what it's called, something in reflexes, whatever. Proprioception reflexes, like 3 or 4 PDF files in there. Scan through one and you find one that goes over these reflexes quite easily and fairly carefully. So the crossed extensor reflex is this. So first of all, on the right-hand side of the diagram, I have the flexor withdrawal reflex going on. So in other words, let's pretend I put my left foot on a thumbtack. The flexor withdrawal reflex brings my foot upwards off the thumbtack. I would then fall over. Because I've lifted my one foot off the ground, I fall over. So to counteract that, we have the crossed extensor reflex, which essentially is the contralateral limb extends while the ipsilateral limb flexes. So you put one hand is withdrawn from the hot plate, the other arm pushes, extends, pushes you away. My left foot goes onto a thumbtack, my left leg flexes, the crossed leg, the opposite leg, extends. So you could draw the neural circuitry of this. You've got to activate the extensors, inhibit the flexors on the contralateral side. On the ipsilateral side, you activate the flexors and inhibit the antagonists, the extensors. One limb flexes, one pushes, extends. So that's the crossed extensor reflex, where you cause the contralateral limb to extend as the ipsilateral limb is flexed. Okay? Before I found that diagram, I did this diagram, and That's probably easy to see. If you follow those pathways, which one's inhibitory, which one's excitatory, you can see how you flex the ipsilateral limb, extend the contralateral limb. But they're not. Remember, if you vary the stimulation, you'll get different effects. In other words, if rather than, you get a baby, you lie a baby on his back and you stick a pin in his foot, he will pull his foot away and the other leg will extend. Okay, that's your cross extensor reflex. But rather than sticking a pin into the baby's foot, you apply gentle pressure with the palm of your hand. What does the baby do?
It pushes against.
It pushes against you. Okay? Different stimulation, exact opposite effect. Okay? And that pushing is known as the extensor thrust reflex. The extensor thrust. You push on a baby's feet, the baby pushes against you. Because it thinks it's the floor, basically. It's an extensor. You push against a surface of support. It makes the baby try to stand up. The extensor thrust reflex. Your extensors thrust outwards when you get a gentle pressure on the foot pads of a baby. Now what happens, of course, in our patient, remember with a stroke patient, all these reflexes are free to do their own thing. The extensor thrust reflex can be a problem. If they do not have inadequate inhibitory influences over this, like Nash has shown in his experiment with the moving platform, some patients, you put the foot down and it just goes bolt upright. It's very hard to get a patient to walk if they've got too much extensor thrust reflex coming out. As soon as their feet touch the ground, they just want to stand rigid, push against the floor, and you cannot get them to flex. They can't get this gait cycle if you've got the extensor thrust reflex is too powerful. Does that make sense? That's something that you're going to have to fight in your therapy. That's why the body weight support treadmill training system, where you hang a patient on a harness, you can lower the patient down to the ground, so there's, and you cut out that extensor thrust reflex. If you put too much weight on the patient's feet, they push like crazy. If you give a gentle amount of weight, you can get them to walk, because you're not provoking that primitive extensor thrust reflex. Try, and if you've got a baby, you've got friends or whatever, but try pushing on a baby's feet, you'll see them push against you. Put a pin into the baby's foot. They'll pull away from it. Okay? Let's look at one step above this. If we go to more complex reflexes, we look at we have tonic reflexes. Tonic reflexes control the tone of certain groups of muscles. They control one part of the body in relation to another part of the body. So tonic reflexes. And probably the most common or well known is the AT&R. OTs heard of the AT&R? Yes, no? No? The asymmetric tonic neck reflex, the AT&R. The asymmetric tonic neck reflex, the AT&R. That's a classic reflex you see in babies when you twist the baby's head to the left, it facilitates the left extensors. You twist their baby to the left, the head goes to the left, the neck twists to the left arm extends, left leg does, right arm flexes. So this fencing position. So PTs have heard of that, obviously. OT, some of you have, some of you haven't. So that's the AT&R. Head goes to the right arm is facilitated. Extension. Left arm is flexed. Okay? And this supposedly is integrated or disappears around about 6 to 8 months, typically. If that reflex is obligatory in a child with CP, you're in a problem. The reflex is thought to be due to looking and reaching. It kind of coordinates looking where my arm is going, reaching and you look. Fine. But I want to be able to turn my head both ways while my arm is extended. If a baby has an obligatory AT&R, the kid's going to have, problems. So you want to be able to dampen that down eventually. And some of your CP kids will have this. You'll see it in brain injury patients sometimes. It re-emerges. But that reflex is within you lot now. As shown, remember this this little experiment by Hillebrand showed that this is a hand dynamometer, just doing wrist flexion, wrist extension exercises. This is normal folk. Wrist extension, wrist flexion. On the left-hand side, you've got wrist flexion. And one on the bottom axis is successive bouts of activity. In other words, they're getting fatigued along the bottom here. But you can see when the head is away from the wrist, they're way stronger, particularly when they get fatigued, when your head is towards the wrist. So if I'm going to do a wrist flexion exercise, I want to have my head away from the wrist, always stronger. If you're doing a biceps curl, you will be stronger if you twist your head over here than if you twist it, if you look at the weight. Much stronger. Okay? Opposite, wrist extension. If you're doing an extension exercise with your right hand, wrist extension, elbow extension, shoulder extension, whatever, if your head is looking, your neck is twisted towards that side, you'll generate more force than if your head was away from that side. Okay? I mean, that's why you go down, you do weights, you do this, down the gym, to be stronger. People used to think this was due to the neck receptors. You twist over here, it does this. I think I mentioned that before. An interesting experiment. If you do this by yourself at home, maybe, you just twist your head to the side with your eyes closed for a few minutes and hold it there. After a few minutes, you perceive that your head is drifting towards midline, even though it's not. So you hold your head over here, after a while you get used to it, and therefore you think your head has gone to the midline like this, and that reflex disappears. And you do that. That's gone. Even though your head is still being twisted over here. Or you can hypnotize people to think their head is over here, and that reflex appears. So it's some kind of perception of your head in space, not the stretch reflexes in the neck, that actually causes it. Quite an interesting reflex, and we're doing some research in my 5th year group on this. Okay, so that's it. The ATN, or the asymmetric tonic neck reflex. In other words, one side of the body does something that the opposite side does. So my arms are not symmetric in this case. You can have a symmetric tonic neck reflex. The symmetric tonic neck reflex is where both limbs do the same thing. Symmetrical across the body. If you flex the neck of a baby, the arms will flex and the legs will extend. So flex the neck, arms flex, legs extend. This is thought to be a remnant of when you're a quadruped and you want to have a drink out of a pool of water. You flex and your arms bend, your forelimbs flex to get your head down to drink, and your back legs stand up straighten up. We still have that primitive reflex within us, and you can see it in babies. It gets integrated, it disappears as the brain matures and takes over that. Alternatively, you tilt the baby's neck back, the arms extend. It's like a protective reflex. That's why it's often so difficult to get a little kid to dive into a swimming pool, right? Arms up around the ears, okay, ready, dive, boom, like that. Nose full of water. Like that. The head comes up as the arms go out and they try to push away from the water. It's not natural to dive into something, head first. So it's a protective reflex. Get away from that thing. Head goes back, arms go out. Okay? That's symmetric tonic neck reflex. We have labyrinth reflexes. I know in Suzanne's, the PTs in Suzanne's class we go over way more in motor development, but we're just going to touch it very briefly just to mention them. So, tonic labyrinth reflexes. What's our labyrinth?
Down.
vestibular system. The semicircular canals, the otolith organs. The vestibular system is our labyrinth. So these reflexes are based on the position of the head in space, where the head is tilted. So, get a baby again. Lie the baby on his back. What you find then with the tonic labyrinth reflexes, the TLR, that all the limbs will extend. Head goes back, lying down, all limbs extend. You put the head face down of the baby, what happens then? All limbs flex. The baby curls up in a ball on the bed. You tilt with the head horizontal with the face down. That's a tonic labyrinth reflexes. And these can be a pain sometimes as it were, if they're obligate, if you can't get out of that pattern, due to brain damage. Let's go one step further and look at some more other things, more in the spinal cord, more other sort of reflex generating patterns. Remember this one, I know we talked about the motor control, quickly review that for the OTs. What we do, what Sherrington did, he got a cat, right? He got a cat and he cut his head off. He didn't cut his head off completely. He sliced his midbrain. He cut the midbrain of the cat. Okay? So the cat's brain cannot talk to the legs. So now the legs are by themselves, the cord has to work by itself. And he put a body weight support, he put a sling under the cat's belly and had the cat on a treadmill. The cat's paws lifelessly hang on a treadmill. You start the treadmill up, the paws drag for a second and it starts to walk. Okay? The cat is walking without a brain. Obviously saying the brain is not controlling, we don't need a brain to walk. Okay? We do some interesting things where he'll tape one of the cat's legs to his chest. Okay, we'll duct tape a cat's leg to his chest, he walks with 3 legs quite well. You speed the treadmill up, the cat runs. You put a cat on a split belt treadmill, and they've got split belt treadmills for patients now, where you put 2 treadmills side by side, with 2 tracks, as it were, 2 belts side by side, and you have a cat walking, you speed up one side, and you slow the other side down. So now the treadmills are going at different speeds. The left leg of a cat walks, the right legs run. Very easily. This cat does not have a brain, remember. But these legs are running, and these legs are walking. You put a piece of elastic tape on a cat's paw, during swing phase, the cat will shake his paw, trying to get rid of it. Okay? So this cat is doing something very clever without a brain. And why is that occurring? How is that occurring? Well, of course, Sherrington proposed this idea of the sponge chaining hypothesis, which basically he said that feedback from the periphery, the sensation my left foot hit in the ground, was a signal for the right foot to move. The right foot hit the ground, signal the left foot. So it's a response chaining. These sensory feedbacks are linked together to cause movement. So the control of this cat was driven by the periphery. That's what Sherrington thought. He got his Nobel Prize in 1932 for doing this work. But then somebody else came along later on, 1911, Graham Brown, did the same thing with a cat. But he then gave them a dorsal rhizotomy. So this cat could walk on the treadmill. Sherrington said it was feedback coming back from his legs, his feet, via these sensory neurons that are coming into the cord that are causing contraction of the muscles. But what then Graham Brown did, he cut the dorsal root of the cat. Okay, he cut the dorsal root so the cat could not get feedback. The cat could still walk. The cat could walk without feedback from the periphery. Alright? Later on, I think it was 1981, a very famous experiment by Grillner, is it on there? No, Schick's work. Grillner did this. Okay, I'll tell you something, but you've got to forget it completely as soon as I tell you, because it'll just confuse you. There's some evidence that some sensory feedback comes through the ventral roots. Okay? I've been telling you 99.9 every single time, all the feedback comes through the back, right? There's some evidence that there's a little bit goes to the front. Okay? So don't ever think of that in the boards question. You'll never ever get to that level of thinking. You know, they won't ask that kind of question. So what he did, what Wilmer did, was he paralyzed the muscles with curare. This is what's known as fictive locomotion. This is the ultimate experiment to figure out what's going on. Fictive locomotion. So what he did, he got this cat, he cut his head off, he cut the brainstem. He cut the dorsal roots, so you can't get feedback. He paralyzed the muscles with curare. Okay? Okay, curare blocks the acetylcholine receptors, so the muscles cannot move at all. Alright? And there was some thought that maybe the walking of the cat, even though you cut the dorsal roots, the vibration of the feet made some kind of feedback, whatever. So the cat's legs are paralyzed, the cat can get no feedback whatsoever. He puts electrodes on the ventral roots. He puts electrodes on these alpha motor neurons coming out. And then he just dumps some electrical stimulation into the cord. He just shocks the cord. He just stimulates the cord, not physically, just gives a background in stimulation to the cord. And lo and behold, out of those ventral roots comes flex, extend, flex, extend, flex, extend, flex, extend. The cat is walking, trying to walk. The cat has no feedback whatsoever. The cat has no brain sending signals to the cord, but the cat is essentially electrically walking. Electrical signals are coming out of the cord to walk. Left, right, left, right, left, right, left, right. So what the heck is going on? Later on, I'll tell you what's going on. There are central pattern generators, or sometimes called neural oscillators, sometimes called spinal pattern generators. And what they look like, the simplest version would be this. Command neuron. A little circuit of neurons that is the most simplest spinal pattern generator you can get. This is the command neuron. This is usually from the brain. It doesn't have to be though. Once I get this little oscillator circuit going, it causes flex, extend, whatever, of muscles, or left, right. A little circuit goes round and round. So flex, delay, extend, whatever, extend first. Extend, delay, flex, delay, extend. That is a central pattern generator that will drive your limbs to walk. Without any feedback, without any brain, whatever. And these neural oscillators or central pattern generators are thought to be in the core. And they drive our action, they drive movement, they drive gait. And this is what we're trying to access now with our body weight support treadmill training. So now they're looking at spinal cord injury. Can you put electrical implants in the cord to get this thing to walk without having a brain, a person? Spinal cord injury. Can we get spinal cord injury patients to use these central pattern generators without having a command neuron from the brain? If we can stimulate this, we can get the person walking electrically. Because these circuits are within the cord. Okay? Another interesting. How can you tell if these circuits are learned? Did the kitten or whatever learn to? Are these circuits develop with experience. How do you determine that?
Take a kitten.
Take a kitten. You're a chronic spinal cat. You get a kitten, as soon as it's born, you get in there and slice the midbrain quickly. This kitten is not funny. I like it. You get a cat before it's ever had a chance to walk, and you cut the midbrain, and you do this experiment with him, and lo and behold, the kitten will walk. Which says what? These are inbuilt, innate, pre-wired circuits. You are born with these circuits. You don't develop them. They're there already at birth. Okay. Now, it's a lot of work. Interesting, one last thing about these spinal pattern generators that has some clinical relevance. Pearson did a lot of work on cockroach gait. And he came up with a central pattern generator of cockroach gait that they think applies to us. I mean, cockroaches and us, we walk very similar. As we do. You have anti-phase, one leg goes forward, the other goes backwards. Same kind of thing, okay? We also find this. What's this? What animals are these? A cat and a cockroach. You could put a human on here as well. You have the same pattern. So when you go, when I speed up walking, go to walking, to jogging, to running, to sprinting, how do you go faster? Remember in gait, there's two cycles, right? A swing phase where the leg is in midair, and a stance phase when the foot is on the ground. You've got a swing and a stance phase. When I go from 1 mile an hour to 5 to 10 to whatever, 15 miles an hour, how do I go faster? What is it that goes faster?
Stance phase?
You reduce stance phase. And every animal does this. Swing phase stays relatively constant across speeds. In a cockroach, in a cat, in a human, in an elephant, whatever. So you can see this diagram, it's kind of backwards, but this is going to the left is faster. Cycle time. In other words, the animals are running faster left axis if you go on a horizontal leftwards, this way. So as you can see, swing phase in this cat, as the cat goes faster, the swing phase basically stays the same, doesn't it? Same time for a swing phase. But stance phase, the amount of time on the ground decreases drastically. Same with a cockroach, same with a human. So when I'm running, what you're doing when you're going faster, your foot is on the ground less time. The leg swings basically the same amount of time. Okay? As a cockroach, as a human, as a cat, as a whatever, horse. You find this relatively same thing. So Pearson model of a spinal pattern generator for a cockroach is this. And this is what people basically think works for us too. This general principle. Okay, let's look what happens here. Command neurons from up here, from the brain. Notice the extensors are tonically activated. In other words, the extensors in this model are always on. There is always background stimulation to the extensors. Very good. It makes it stand up. This is a postural kind of tone. The extensors are continually on. Now I want to run. So what you do is you send a command from the brain down to this little circuit here. This is a flexor burst generator, a flexor spinal pattern generator. And what that does is periodically turn on the flexor muscles. To do that, you have to turn the extensors off. You can see this inhibitory interneuron here. It turns the extensors off. Remember that the extensors are on continually? So, to be able to run or walk or whatever, you've got to turn the extensor background tone off and then flex. Turn the extensor off and flex. Turn the extensor off and flex. So in actually control the flexes of this burst generator, and you turn the background extensors off. Does that make sense? So if you damage this up here, you damage your central commands, what's the patient's natural posture going to be? Extension. If you damage that flex the burst generator, the muscle is going to be on, tonically, extension. Does that make sense? I guess there's something else about that, but I've forgotten. Anyway, so, the theory goes, we have these spinal pattern generators, these central pattern generators, within the cord. And these are very important for gait. And we think soon we're going to be able to tap into these electronically in rehab. And this is what we do in the bodyweight support training. People walk on a treadmill. Treadmill training is great. It's effective for Down syndrome, for cerebral palsy, for stroke, for TBI, for spinal cord injury. We are getting the cord walking. We don't need a brain to walk in most situations. If you look at this cat though, let's say you record from a cortical, let's get you a normal cat on a treadmill, right? You get a normal cat on a treadmill, and you record from his corticospinal tract. You have him run on the treadmill, you see no activity coming down the corticospinal tract hardly at all. But then, you stick wooden blocks, you glue wooden blocks onto the treadmill. Now the corticospinal tract goes crazy firing. Because the cat needs to dodge the blocks with his feet. You have to adjust this automatic. So I can walk quite easily with my eyes closed without a brain. You cut my head, a chicken runs around the farm with his head cut off, doesn't it, for a few minutes. That's what's going on. The spinal pattern generators are just walking away. But if I want to adapt that spinal pattern generator, I need a brain. If I want to dodge, step over this crack in the floor, go around that block, lift my foot higher, whatever, then I need a corticospinal tract to modulate these pattern generators. Vision. I see something, I move my legs slightly left, or I change the pattern generator. Does that make sense? So I quite foresee in the future we'll be able to walk without a brain electrically. They're doing that now. They're experimenting with putting implants into the cord at various levels. Alright, any questions? The spinal cord is a very clever thing. Okay? And we use that in our gait. I know that. Okay, let's look. Stop that. We'll introduce now our pathways. We're now going to look at those pathways we've mentioned in brief in more detail. So we're going to go through all those pathways and add some more now. So we all should know the basics of these pathways. The first, second, third order neurons. Now let's add a little bit of complexity to it to see what's going on. This is our pathway for pain and temperature. We've gone over this before. Different receptors for pain and temperature, whatever, maybe sometimes the same, but this is a general pathway. The pathway comes in, remember, dorsal root, synapse is in the dorsal grey horn, okay? That second order neuron crosses to the other side of the cord at the segmental level, right? This is all just review. It goes across through the white commissure here, goes to the other side of the cord, and ascends in the lateral spinal thalamic tract. That we know so far. Okay? The lateral spinal thalamic tract goes all the way up the cord, ends in the thalamus, and a nucleus known as the VPL, or ventral posterior lateral nucleus. One of those nuclei within the thalamus, the ventral posterior lateral nucleus. That's where this signal ends, the second order neuron. The third order neuron takes over there and of course goes out to the somatosensory cortex. Alright? We have different types of pain fiber coming in now. We've all just lumped this generically that pain comes in, whatever. Before we get to where each go, where they go, what goes where, so far we've just labelled the grey matter as horns, or whatever. And dorsal grey horn, ventral grey horn, lateral grey horn, commissure. But, let's look at more detail now. Within that grey matter, there are lamina, layers. People have defined layers functionally within and structurally within that grey matter. And they're labelled Roman numerals. One is at the very, very dorsal back tip. So basically we layer them or label them 1, 2, 3, 4, 5, 6, 7 from back to front. These are often known as Rex's lamina, R-E-X-E-D on the bottom there. Okay, so just be aware for now that there are different locations within this grey matter called lamina. Different layers of grey matter. Alright? And they're labelled Roman numerals 1 to whatever from back to front. Now, bear that in mind when we look at this diagram. This is our pain fibers. Remember we have two basic pain fibers coming in. The A delta fiber and the C fiber. The A delta is also called type what? 3. C fibers are? What are C fibers? 4. We've got 3 and 4 coming in, right? Based on the thickness of these fibers, or A delta and C fibers. What do C fibers carry? What type of pain? Dull, slow, burning, aching, throbbing pain. What are you going to call it? Whereas the A delta fibers carry that sharp, prickly pain, a pinpoint of a pin sticking in your skin. That's the kind of pain that brings in. Okay, let's look at those A delta fibers shown here. The A delta fiber comes in and synapses in lamina 1 and lamina 5. Okay, so the collaterate splits out those A delta type 3 fibers synapse in lamina 1 and in lamina 5 of those layers of the grey matter. They then directly synapse with second order neurons. You can see them here, these red blobs, those are cell bodies. So the second order neurons starting in lamina 1 and in lamina 5 that then do whatever we've talked about before. Those second order neurons then go across the right commissure, go to the spinal thalamic tract, etc., and go up to the VPL. Okay? So that's the pathway for this prickly kind of pain. However, C fibers do something different. C fibers, that type 4 fiber, slow, aching, throbbing, burning pain, whatever, they synapse in lamina 2. And then there's another common name for lamina 2. Pain gate theory, you've probably heard of that. The substantia gelatinosa. Has anybody heard of that one? Have you done that in physical agents? Yes? The substantia gelatinosa, a jelly substance. Substantia gelatinosa. I think that's how you spell it. The substantia gelatinosa is another name for this lamina 2. So your C fibers synapse at lamina 2, or in the substantia gelatinosa, with an interneuron. A little interneuron comes in here, which then connects with a second order neuron in lamina 1. Okay? So they go a different way. They have an interneuron in lamina 2, substantia gelatinosa, but they then eventually end up on those second order neurons that cross the midline and go up the lateral spinal thalamic tract. The other interesting thing to note is these A beta fibers coming in. What are they innervated by? Where are they coming from? These are proprioceptive or our pressure fibers or other sensory. These aren't pain fibers come in. These are mechanical deformation fibers. And they come in and look how they synapse on the dendrites of these second order neurons. That makes sense. This is the reason if you get a pain in the arm, what do you do to stop the pain? Rub it like crazy. You rub it. You bombard the pain fibers with mechanical stimulation. The pain goes away. It appears less. This is the reason why within this area here. Let's go back to this diagram. So we've got our pain into the cord via C or A delta fiber. So it's crossing and it's going to ascend within the lateral spinal thalamic tract, which is here. You can see the lateral spinal thalamic tract on this diagram. Okay? Not in that pink there on the right hand side. This tract itself is somatotopically organized. The actual tract is organized depending on where in the body things come from. The lower extremities are more lateral, more peripheral. As you go deeper through this tract, you get to the upper extremities. It's not been shown there, you can't see it there, but the lower extremities are more lateral, like the feet are on the outside of this tract, the arms and hands and etc. on the inside of the tract. Now, we'll add one more bit of detail here, unfortunately, which is clinically relevant. Okay, we have overlap within the cord. We have overlap. The last thing we'll discuss and I'll stop. We also, before we get that, we actually have overlap in our dermatomes. Are you familiar with dermatomes? Don't you? You've done dermatomes, yes? Mm-hmm. So you previously we've said, I know in my anatomy we've said this, basically. This is, let's say, C3, 4, and 5, right? Whatever. And they're separate slices of the skin. In fact, generally, these will overlap slightly. So you find overlap of these dermatomes. So you do overlap, and each person will vary, unfortunately. But usually there are certain areas where you find only one nerve root. Or some professors will argue there's not. Art will say it's all overlapping. But there are usually, most texts will say there's certain areas that you can pinpoint on where you will find C5, C6, C7, whatever. So there's overlap on the periphery, but there's also overlap when we get in the core. Okay, so this is what happens. That diagram at the bottom is not very clear, so I'll draw it. Here's the cord. Here is the pain fiber coming in. Can you see that? It's not a good pen. That's all we've done so far, right? Pain fiber comes in, synapses at segmental level and crosses over, second order crosses over. But in reality, this is what happens. Okay, So that neuron that came in, as well as synapsing directly at the segmental level at T5 and going across and over and going up, it sends off collaterals. As soon as it gets into the cord, the very instant it gets into the cord, it sends a collateral that goes up 1 and 2 segments and down 1 or 2 segments, which then synapse with second order neurons at different levels. This portion here, right at the very tip of the dorsal grey horn, is called Lasauer's tract, or the dorsal lateral fasciculus of Lasauer. There it is, it's on there. This term here, dorso-lateral fasciculus of Lasauer, or Lasauer's tract. And you can see it here. Just off here on this one you can. Lasauer's tract. The very, very, very tip of the dorsal grey horn. So there's a little overlap in the cord here. Why is this important clinically? Okay, I now give you a lesion at T5 on this person's left-hand side. At T5. Where do you lose pain and temperature from? Contralateral, ipsilateral? Contralateral. At what level do you lose it from? 1 or 2 segments below. Previously we said, okay, if I give you a lesion here at T5, I have lost T5 sensation, right? No. You do not. Because look, this goes up and gets around that lesion. You will probably not lose T6 either. But you'd lose T7. Because of Lasauer's tract. So when you get a cord lesion, like a Brown-Séquard lesion, you lose pain temperature for contralateral side, but usually one or 2 segments below the level of the lesion. Because of Lasauer's tract. Is that a lot to digest today? Sorry. I didn't invent this stuff. Read the chapter in the book on the cord. It's all in there. The cord chapter. The spinal cord chapter. It's all there.
Yeah, basically.